All right. Good afternoon. Thank you, everyone, for joining us today. This is one of our very special grand rounds where we invite someone outside of nephrology to talk on a topic that's relevant to both nephrologists, but also other specialists. And Dr. David Chu is a pediatric urologist who is truly interested in the kidney and specifically in the right way to measure kidney function in a population of patients that he takes care of in his clinical time, but also uses for his research, and that's the Spina Bifida population. And I know there are some fellows here who probably took care of recently of a dialysis patient with Spina Bifida who often comes into the hospital. So we do definitely see these patients as they become adults, but he works with the pediatric side of things. So a little bit about David. He trained at very premier places. So he did his undergraduate at Yale, where he graduated magna cum laude with distinction in his major and received the Dr. Alan Bromley Undergraduate Prize in biomedical engineering. He then went on to do his medical school training at Weill Cornell Medical College, where he received several awards and distinctions. Including the prize for excellence in urology. And then he went to do his internship and residency at Duke, followed by a fellowship at the premier children's hospital, the Children's Hospital of Philadelphia. So as you can see, he's extremely well trained, and he was very highly recruited here in 2017 and started as an assistant professor. And within 6 years, his career just opened up. He received funding, he published a ton, and he very easily got promoted to associate professor in 2023. So I mentioned already that his beloved patient population is the Spina Bifida population, and that is who he takes care of surgically, but also is the focus of his research. The project that he'll hopefully talk a little bit about today is the right way to estimate kidney function in that population, and he'll, I'm sure, allude to the challenges that exist with sort of figuring out what is the right way to measure kidney function. But he also does collaborative work with other people who work nationally in the Spina Bifida space. He's on many committees. And then on top of that, he also works with several colleagues at CHOP on kidney stones in the pediatric population. He also finds time to be an assistant editor for the Journal of Pediatric Urology, gives lots of talks nationally and internationally, mentors many students, residents, and fellows, and has accumulated a very robust publication record, and he still keeps going. And I've had a chance to work with David, and I always say it's just a pleasure to work with surgeons, because once they commit to something, they go all out and they get it done. And David is definitely an example of that. So David, thank you very much for your time today.
Thank you, Tamara, for that very kind introduction. I've been mentored by Tamara ever since I joined Lurie and Northwestern. So it's been tremendous to work under her tutelage and guidance. It's a pleasure to be here in the nephrology grand rounds. Title of my talks here. Let's see if this button works. My disclosures are here. A couple grants, no conflicts of interest. I attended a talk when I first joined as faculty, and someone presented a positionality statement, which I thought was interesting. So I started kind of incorporating this just to kind of give you a little more context. You heard my CV, just to give you a little more context about who I am and placing my talk within that context. So I've been fortunately married for the last 13 years. I have 4 young kids, and I was telling Tamara I recently got a puppy. Just, we're crazy, but kids are young, 2 to 10. I've been at Lurie since 2017. If you count the PGY years, it's up there, 17. So year 8 of being an attending now. I'm on my last year of my K. I got this, fortunately, when I was a third year out attending and wrapping things up and trying to play the grant lottery to try to get something bigger. So I have played this multiple times and not won multiple times. So we can talk about that later if you have questions. I'll also tell you what I am not, and I am not a nephrologist. Okay, so any questions, thoughts, opinions, just keep that in context. I'll break my talk into a couple key objectives here. The first, we'll kind of talk about the background, some definitions of the epidemiology of CKD and spina bifida. A big chunk of this talk will be focused on kind of knowledge gaps and pieces that currently are missing from the clinical care of kidney health in the patient population with spina bifida. And lastly, we'll touch upon some future studies, future research, kind of future directions. So first off, what is spina bifida? Those of you in clinical care probably have taken care of people with spina bifida. It essentially is when the spinal cord does not close normally. And so in this most severe form, as shown in a picture here, called myelomeningocele, you have a defect in the spine and protrusion of part of the spinal cord. And so you get a lot of neurologic problems later on, which I'll touch on. The incidence is pretty rare, 3 to 5 per 10,000 births, lower after folate fortification and diet, but still very, very prominent because it is the most common permanently disabling congenital birth defect in the United States. Its burden is huge, all right? So from a cost perspective, estimates have shown that it's about $800,000 more per live-born infant with spina bifida compared to a healthy control otherwise lifetime. There is, as I mentioned, a lot of downstream neurologic sequelae. So the brain's affected, you have hydrocephalus, oftentimes they require a ventricular shunt. You have neurogenic bowel leading fecal incontinence, constipation. The legs, oftentimes ambulation is affected. And then obviously in urology, we'll carry about the bladder, and I'll touch on that later. But multiple organs are affected downstream permanently. One thing that is positive but also negative is that 50 years ago, a lot of patients died of spina bifida young. But these days, with the advent of management, we've been able to allow people born with spina bifida to survive into adulthood, which basically means that the burden on the healthcare system is only going to increase. So where do the kidneys come in? Well, I mentioned the neurogenic bladder. So that leads to increased chance of urinary tract infections, vesicoureteral reflux, when urine goes from the bladder backwards up to the kidneys, and then chronic high bladder pressures, which can also cause some hydronephrosis up in the kidneys and potentially alter glomerular filtration later on. CKD, chronic kidney disease, also confers additional synergistic effects to those already mentioned with spina bifida itself. Examples specifically be hypertension. Definitely higher risk in people with spina bifida, fractures as well compared to otherwise healthy controls. Both are often, as you guys know, associated with CKD as well. The lifetime prevalence is higher, all right? So these are studies that have shown that in the spina bifida population, lifetime prevalence of end-stage kidney disease is about 1 to 2%, compared to the general population of about 0.2%. That's 5 to 10 times higher lifetime prevalence. But as if this isn't bad enough, it's not just about lifetime prevalence, it's about when that ESKD is reached. So Judy Thibodeau is a RN who was at CDC, and most recently she became director of research at the Spina Bifida Association, which is the biggest kind of advocacy group in the United States. So back when she was at CDC, she performed this retrospective cohort study using the US RDS. She matched patients 1 to 5 with and without spina bifida and looked at cumulative incidence in transplantation and death and also adjusted for a couple of covariates here. So she found 440 patients with spina bifida, matched to about 2,000 patients without spina bifida. And a couple things that she found. The first is that among people with spina bifida, end-stage kidney disease was reached decades earlier, mean age of 41 compared to mean age of 62, all right? So 2 decades earlier, younger. Most patients had a urologic cause of end-stage kidney disease. The rates of UTI hospitalization were also higher. When they looked at kind of the survival analysis, they found that they were less likely to get a transplant, but overall the incidence of death was not different. But the big question remains, why do patients with spina bifida reach end-stage kidney disease 2 decades earlier than those without spina bifida? All right. So one question is, when does CKD begin before reaching the end-stage kidney disease? You guys are all nephrologists, so you guys know about this CKD stage and how it progresses from stage 1 all the way to stage 5 or end-stage kidney disease. The idea, though, is to identify CKD early enough that you can intervene early enough to prolong or delay that progression. Essentially, the gray bar kind of shown here in this graph. And so one question that arose is, does CKD begin at birth? All right, we know that there's this congenital birth defect, the spine's affected, how much of their kidney function at birth is also affected. So this study was actually done. Stacey Tanaka is a pediatric urologist down at UAB. She and I and many others are part of the CDC-funded study called Umpire. It's a 9-center prospective QI study. Part of the protocol is infants are enrolled at birth. We get an ultrasound within 1 week after birth, and then we get some baseline testing, a VCUG to look for reflux or video urodynamics to look at bladder function, MSCE to look at kidney scarring at 3 months. And we looked at outcomes, all right, in this study. We found 193 patients. Key findings here: hydronephrosis, just 4% in high risk, all right. Reflux, 9% had bilateral, what they considered high risk, the authors. And DMSA scarring is only found about 8%. So overall, one might suspect that, hey, newborns overall have mostly healthy kidneys, okay? So that leads us to kind of this quick summary here. We know that in people with spina bifida, kidney health is mostly okay at birth. But we also know from the US RDS that end-stage kidney disease is reached by the 4th decade of life, all right? So that kind of begs the question, is CKD the missing link in these kind of kidney outcomes? And I posit that indeed it is, all right? So now we'll kind of move on to the second part of our talk here. So I'll slow down a little bit. That's just the background. So some of the questions, knowledge gaps that can be identified are, well, first off, how accurate are current CKD diagnostic tests, okay? Audience poll, just raise your hand. If you have a stable patient with spina bifida, how do you routinely check their kidney health? So A is just creatinine-based EGFR, B is cystatin C, C is both, D is urine, E is ultrasound, F is other. So raise your hand if you do A. Raise your hand if you do B. C? D? E? Okay. And then anyone have any other suggestions? C and D? Okay. All right. So it seems like a lot of people use the combined EGFR equations and ultrasounds in people with spina bifida. So this is, I mean, I'll be preaching to the choir. So this is a KDIGO guidelines, right? And a new one just got published in 2024. This probably looks very familiar to all of y'all. We know that CKD is diagnosed predominantly 2 ways. One is via the, let me try this out here. Can you see that? This is so cool, pointing at the screen. You have the EGFR here, and you have the albuminuria here, all right? Important update in the 2024 guidelines is that the authors now say that for children and adolescents, an EGFR of less than 90 is considered low, okay? And this is great because this is something that we've been doing in our urology spina bifida clinic for quite a while. But previously, this guideline, this update was not present in the 2012 KDIGO guidelines. We also know that CKD can be diagnosed via structural abnormalities, all right? So the next parts, I will talk about kind of those 3 ways: EGFR, urine studies, and imaging as ways of diagnosing CKD. So what about EGFR equations? We know that there's a couple problems with them. The first one is that they were derived in patients without spina bifida, all right? If you look at CKID, if you look at CRIC, CKID actually excluded people with neurologic CNS issues, central nervous system issues. So no patients with spina bifida were included in CKID. The second is that a lot of our patients with spina bifida cannot stand, all right? So oftentimes an arm span is used as a proxy, and studies suggest that tends to overestimate height by not much, maybe 5-6%, but height can be inaccurate. And muscle mass, we know it's a muscle wasting kind of a disease process, and creatinine reflects muscle mass, so it's lower in patients with spina bifida. So this is a bedside Schwartz equation from 2009. And so basically, if the height's overestimated and creatinine is lower, then the eGFR, just by simple math, is overestimated. So this is not new. This is the earliest paper that I could find, 1997, that showed that creatinine was not a reliable indicator of GFR. And this graph on the left, they essentially look at creatinine itself. And in better correlation with an eGFR formula, and this is from Short's, like one of his original ones from 1987. So we thought when I first joined to look at, hey, what about contemporaneous equations? So Cam Arkin was a research coordinator at the time. She's now a medical student, finishing up at University of Utah. But she helped perform a single center retrospective study. We had two analyses. One is cross-sectional. We looked at kind of concurrent eGFR equations using this coefficients of variation, or CV, essentially to assess reliability. And the lower the CV, the better. We also looked at stage classification, and we performed longitudinal analysis to look at the slopes, right? eGFR decline over time from these different equations. So these are the equations we used. The Betz-Schwarz, again, this is back in 2019. The Zappitelli one is interesting because that was the only one in the literature at the time that actually had an adjustment for spina bifida, all right? But it was only based on 11 patients. But we used that kind of spina bifida specific equation because it's the only one in existence. And we show here kind of the different factors used. We use the CKD epi equations for adults. So 182 children, 75 adults, and this is kind of what we found. You can just kind of tell that these are the median eGFRs per equation on the x-axis. And so Betz-Schwarz 144, if you use a cystatin C, is 86. So huge, huge variability. And for the clinicians in the room, you probably noticed this too. Maybe like just seeing patients, you're calculating them like, whoa, why am I getting like such huge variation from equation to equation? So what we found is basically creatinine is terrible, right? The Betz-Schwarz had the highest eGFR and also the highest CV, which again wants to be low to be good. This is by stage classification. So what's in yellow here is an eGFR less than 90. So if you look at just the yellow bars, you can see by equation, the Schwarz had only 4% with an eGFR less than 90. The Zappitelli gave 71% of the cohort who had an eGFR less than 90. In blue here is eGFR less than 60. And you can tell it's not as variable, but still not bad. Still not small, from 1 to 10% difference in the pediatric equations. What's also interesting is the longitudinal analysis. So here we show that over time, the Betz-Schwarz creatinine-based equation actually gave a positive slope for kidney function over time, whereas all the other ones showed a decline. If you use cystatin C, if you're a cystatin C believer, that decline is actually pretty high, -5 units per year, and they're all significantly different. So this is kind of the first study that kind of jump-started my interest in this area, and I'll go over kind of into some more later. But moving on to the second diagnostic test, all right, urinary markers. There's only one study to date. This is Brian Becknell. He's a pediatric nephrologist at Nationwide Children's Hospital. So he published in 2019 a pretty small cohort study where they looked at catheterized urine randomly collected. And then as the gold standard, they based it on cystatin C equations and basically looked to see the proportions of albuminuria. They had 40 patients, and their key finding is basically that 15% had an eGFR less than 90, but 32% of the cohort had albuminuria. And so one idea proposed is whether albuminuria may precede eGFR changes in this population. But again, this is kind of the only study that's looked at urinary markers to date, so very limited. Kind of similar to kind of the poll I took earlier. So what about imaging? So Lauren Bonner now, but I met her when I joined because we started at the same time at Lurie and Northwestern. She helped us with this study. We looked at cystatin C only equations and looked at ultrasounds. Again, the CKD, the KDIGO guidelines say that structural imaging findings are suggestive of chronic kidney disease. So we looked at hydronephrosis and specifically the sensitivity specificity of hydronephrosis for an eGFR less than 90. A couple sensitivity analyses shown here. We had 250 patients, average age about 14. And what we basically found is that hydronephrosis is a poor screening tool. So ideal screening tool should have a sensitivity of 100%. We found it to be no better than 50%, maybe as low as maybe 23% for any hydronephrosis. And we looked at our sensitivity analyses, the numbers weren't much better, okay? So lately, we just published this recently, but we decided to look at this in a bigger population, not just the umpire registry with the CDC, but also this other bigger one called the National Spina Bifida Patient Registry, also from the CDC. We try to homogenize our patient population to the most severe type of spina bifida. They don't have cystatin C in these cohorts, so we use the bedside shorts. So that was one major limitation of the study. And the same outcomes, same analyses for test characteristics. Here are the numbers, 220 versus 2,000 patients in the registry. And basically similar numbers, all right, for sensitivity, just poor, 24%, 10% for high grade. Bottom line, hydronephrosis, we check ultrasounds. You know, you guys raised your hand for ultrasounds as a way to screen, right? It is not a sensitive marker for low kidney function. So what are the kind of to summarize, what are the implications of these findings so far? So first off, creatinine is terrible. Don't use it. Second, albuminuria has potential for maybe early marker preceding EGFR changes, and hydronephrosis on imaging is not a great test to screen. So bottom line, we need better tools to assess for kidney health. So a second knowledge gap. We know that these tools aren't great, but in reality, how often is kidney health screened? Okay. So of course, there's guidelines for this type of stuff. And here's a summary table of them, all right? A couple things jump out. The first is that you notice that, and this is kind of verbatim from these guidelines, a lot of the guidelines are very non-specific and very vague. They just mention periodic kidney function surveillance, periodic kidney imaging surveillance, maybe just regular or not even mentioned kidney function testing. What is agreed upon is that pretty much every guideline says it's a lifelong issue, okay, in patients with spina bifida and neurogenic bladder, from birth all the way till death. The NICE recommendations are probably the most specific, probably not a big surprise, and they actually recognize creatinine's limitations and actually recommend isotopic GFR test. But aside from that, that's the only guideline that was specific. So the SBA, the Spina Bifida Association, published these guidelines, their own guidelines for the care of people with spina bifida. David Joseph is a pediatric urologist at UAB. He's actually our visiting professor later this year, if you're interested in hearing his talk. But he led this urology group, and these are the recommendations from the group. And you'll see that they still condition, right? For children 1 to 6, they still recommend checking labs only if the upper tract shows changes, all right? You know, we published our paper after this guideline came out, but you know, we basically show that hydronephrosis by itself is not a reliable, not a sensitive indicator for kidney function. So one question is, well, okay, those are the guidelines. You know, oftentimes guidelines don't make it into clinical practice. What do clinicians do? So Dr. Wood, Hadley Wood, is at Cleveland Clinic. She's an adult urologist. She surveyed a bunch of people, a bunch of urologists who work very closely with people with spina bifida, and asked them what they do for surveillance, much like I did earlier. So 55, just over half, do an annual imaging test, most with ultrasound. Most check a serum creatinine, but only 17% check a cystatin C, okay? I know that cystatin C is maybe kind of king in nephrology, but there is a serious lag of data from the nephrology world into the urology world. It's a very slow trickle. So if you work with a friendly urologist, you know, ask them to check cystatin Cs, because in the real world setting, it is not used often. And then we sought to look at what the spina bifida clinics do. So Kevin is a statistician at CDC. We looked at the registry data. In 2013, the registry started capturing kidney ultrasounds and serum creatinines. And so we created this 2-year window, okay, surveillance window, at their first visit after 2013. And we define our outcome, kidney function surveillance, as at least 1 serum creatinine and ultrasound anytime during that 2-year window. Okay, so that's if they got 1 of each, then they check the box for meeting this outcome. So at 5,000 patients, 23 centers, this is kind of the cohort characteristics. This bubble plot essentially shows that the kidney function surveillance across these, specialized centers, right, who care for people with spina bifida, is suboptimal. The 2-year window rate was only 62%. Okay, and you notice that it didn't really vary by clinic size here. When we broke it down into kind of the individual parts of the definition, ultrasound, most people got, okay, 93%. But again, labs were lagging, just 69% check creatinine. So it suggested basically that, well, to summarize, most guidelines were not specific, not variable. Maybe that's part of the reason why clinicians, don't really check often, the labs. In practice, ultrasound is more commonly used. We previously have shown, that hydronephrosis has low sensitivity for low kidney function. And in practice, the SAN-C is just not checked enough. All right. And so that's something that we've been doing at Lurie, but that's really not reflective across the country. So we don't just need better tools. We need better kind of strategies, more evidence suggesting which strategy for surveillance is most ideal. So a third question: what happens in emerging adults, right? Sibel Gosain is the transitional nephrologist, comes to Lurie and at Northwestern here. But we have a transitional urologist too, who sees patients with spina bifida at Lurie and at Northwestern. So what happens in them? So we know that emerging adults already face a lot of challenges. The American Academy of Pediatrics has kind of developed this kind of framework for helping to guide that transition process. And CKD, there's also a lot of literature out there kind of highlighting how, people with CKD, children who, grow into adulthood also face difficulty with which equation to use when. And importantly, all these studies kind of agree emerging adults, so essentially 18 to 26, 18 to 30, are neither children nor adults. They're kind of their own group. So Diana Bowen is that transitional urologist at Lurie Northwestern. We looked at our own data. We looked at 18 to 28-year-olds. And so since the eGFR equations changed after age 18, we expected changes in the actual eGFR. So we looked at different equations, but the metric was this pairwise % relative difference. Okay, so basically, if you have only creatinine labs, then we looked at a pediatric creatinine equation against an adult creatinine equation. If you like cystatin-C, we paired the pediatric cystatin equation with the adult cystatin-C equation. Okay, so basically what lab data you have available, we pair those equations. So 75 patients. And what we found is that overall EGFR increases by about 25%, all right, just when they turn 18, if you use an adult equation. And frighteningly, this is also true for cystatin-C, all right? When we think like, okay, creatinine is terrible, you expect to have creatinine, but you thought cystatin-C was like, the good one, right, to kind of hold steady. But no, it actually increased 27% more than the other ones. So when we looked at CKD stage migration, it's kind of frightening, right? Up to 39% of patients downstage from eGFR less than 90 just by using the adult version of that equation when they turn 18. So this may be, again, common knowledge to you guys, but it's just this thought that, hey, is this bump essentially kind of masking true CKD in the adult nephrology clinic when you see these kids? And cystatin-C is not immune to this. So it certainly adds, at the very least, barriers to what's faced by emerging adults with spina bifida, in addition to there are many other barriers, but something to keep in mind. So last part of this talk is kind of talk about, well, okay, so it's a very dismal, pessimistic talk you're giving so far here. What can we do about it? So next steps. We need a gold standard comparator. All right. So a lot of studies have, kind of confirmed or backed up our findings. Basically, the creatinine equations suck, and that cystatin-C may be better, but either way, not many people have. There's no CKID cohort, right, or CRIC cohort with iohexol plasma clearance test as a gold standard, right, to really know what the true GFR is. Well, guess what? We have one. So we did this iohexol plasma clearance gold standard at Lurie. This is the CKID protocol. It's a 2-compartment model where we collect samples of 4 times over 300 minutes. Um, so PRAM was created shortly after I joined. Again, Cam started it when she left for medical school. Josie's kind of been the rock star research coordinator. Prospective, we enroll patients 6 and older, and that's because of IRB, just from the degree of blood draw. We're kind of capped at 6 years old for weight limitations, only with that severe type of spina bifida. First enrollee was in January 2019. Everything was going swimmingly, and then come 2020, and the pandemic hit. So, 2023, we started repeat studies about 2 to 4 years after the baseline. And these are our procedures. So essentially non-fasted serum and urine samples for a biorepository, which I'll touch on later. Baseline labs, anthropomorphics, and then the 5-hour clearance test. So, sneak peek, first time published or first time presented. We've completed 77 unique participants. We've completed 98 iohexol plasma clearance tests in 77 patients. You can see kind of their clinical characteristics here. Their median MGFR, measured GFR, was 94. So again, we're not talking about like CKID GFR like 50 or 45 or quick level stuff. Most of these kids do not have severe CKD. I like to think that's because we're actually taking care of them well, but maybe also just because we just have healthier people in our clinic. Of note, 37% had CKD stage 2, and just one had a GFR, I think, of 56, so it bumped into the CKD stage 3. So our outcomes, bias and precision. Again, I'm preaching to the choir here. Bias, for those who don't know, bias is the estimated GFR minus the measured GFR. And precision is the P10 and P30. So essentially, the percent within plus minus 10% or plus minus 30% of the true GFR. This is a list of equations we looked at. We certainly, there's a lot more out there, but these are the ones that we included. All right, so the U25 from CKID, the Zappitelli one I talked about, the CKD, and this is from 2012. I know they updated their equations without race. And then a couple of European ones here, the EKFC and the full age spectrum. So bias, just to kind of talk you through this heat map. So green essentially is best, okay? So that essentially is a difference of minus 10 to 10. Warm colors are essentially overestimates, and cool colors are underestimates, all right? So by the column, so the rows here are essentially the equations. Overall cohort is column 1. Stage 1 is this one. Stage 2, MGFR of 60 to 90 is here. And then that one patient with a GFR of 56 is here. So what can you tell? You can tell basically that the U25 cystatin C equation had the least bias, all right? All green pretty much across the board, except for the last column where we just had one patient. The other equations had quite a bit of bias. You can tell there's quite a bit of red warm colors here. For P30, this is slightly different heat map. So essentially, green is as best, and warm colors, the hotter it is the lower the P30. All right. And again, you can kind of tell just from the colors that the U25 cystatin C equation again had the highest P30, and pretty darn good P30. Greater than 90% across the board. For the entire cohort and across the stages. P10 is again plus minus within 10% of the true GFR, and again you can kind of tell that the U25 had the best kind of performance compared to the other equations. So this is kind of new, and certainly I think promising and favorable towards the CKID U25 cystatin C equation, which is important because for the peds urologists, the peds nephrologists in the room, in a normal control population, what's been espoused is the combined U25 CKID equation, including both creatinine and cystatin C. Okay, so but in the spina bifida population, the cystatin C one certainly seems to be the winning equation. What's next for this? Well, we're still going to enroll. I wanted to kind of reach 100 tests before doing this analysis, but we had 2 cancellations, so we're just short. But we're definitely continuing to enroll, and again, kind of doing the repeat longitudinal studies, we hope to kind of be able to provide some sort of longitudinal estimate of change over time to get a sense of their decline over time. The second thing, urine studies. I submitted a small grant. This is Department of Surgery, and it was awarded funding. Basically, I mentioned part of our protocol incorporates collecting urine and blood. And so we have urine samples from these 98 visits that were just primed for analysis. And so that's kind of part of the plan with this AEF grant is to look for urine, albumin, and creatinine. These are kind of the metrics compared to the one prior study from Brian. The larger sample size, we'll have again kind of a little bit longitudinal comparison. And importantly, we do have the gold standard measured GFR. Imaging was the third issue. I really think that this is going to lie in the realm of functional MRI. So those of you who are Northwestern probably know Anand. He's at UIC now. University of Chicago. UIC. And so he published this with Tamara, looking at 122 adults in the combined trial, and basically showed that functional MRI was promising, but not quite independent of traditional markers of eGFR change. And then Rich Lee is a pediatric urologist at Boston. So his group previously published this 6-minute kind of add-on dynamic MRI protocol, and added on for 15 children with cancer undergoing a DTPA scan, and showed pretty good metrics for that MRI component, but not much else has kind of made progress. So I know Anand is kind of looking. He has, I think, funding now to look at functional MRI in the KPMC study. So I think there's a lot of room for functional MRI to be explored further in patients with who don't fit kind of the mold for traditional CKD diagnosis. And then patient-centered approaches. There's a lot of data in CKD literature that patients don't know that they have CKD, right? So this is from Australia. Alison Tong has done a lot of work in this domain. They performed 9 focus groups and basically show that multiple patients did not know about the disease or care about it or lack motivation to support themselves, and just basically shows a general lack of kind of connecting with what the patients focus on instead. And this is a study from CDC. They looked at NHANES and linked it. They used the kidney failure risk equation, and showed that a lot of people, the general population in NHANES, just weren't aware that they had CKD, including almost half of those with higher risk of kidney failure by the equation. So, one main future goal is to kind of ask and talk with patients with spina bifida about their perspectives on kidney health. And so far, my team has done about 11 interviews. We're doing semi-structured interviews with, I think, six kids and 5 parents, just asking them about this, giving them the kidney information knowledge survey, asking them about health literacy, et cetera. So that's more to come. So in conclusion, I think I'm on time here. People with spina bifida are just bottom line high risk, all right, for not just chronic kidney disease, but end stage as well. There's obviously many knowledge gaps that remain to be filled, but there's also many avenues for promising future research. Big acknowledgements to Tamara, as I mentioned. She's been my primary mentor for my KA, and just such a huge reason why my research career has kind of been as it is. So thank you, Tamara, for your patience and for the last minute emails that you somehow returned the next day. Earl Chang is my boss at Lurie and a huge content mentor for me and career mentor. And Kavita is in the room. I don't see any Duke face paint, Kavita. But Kavita is our pediatric nephrologist and part of our PRAM study. And these are other members of our team at the Spina Bifida Clinic and in urology. So thank you for your time. Thank you for paying attention. And I'll take any questions. These are my kids. Thank you.